So why is homelessness a priority for DMH? Well, as Peter said, if there's 47,000 people who are homeless in Los Angeles County on any given day, and 30% of those have a mental illness, we know that we play a huge part in the process of ending homelessness in Los Angeles. Our mission at DMH is to support the recovery of individuals with mental illness. And according to SAMHSA, recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And you can see if you're living on the streets, focused on survival, it's very hard to be focused on your recovery. It's very hard to live a self-directed life, focused on health and wellness when you're living on the streets. So our goal at DMH is to work with our clients who are homeless, to outreach to people who are not our clients yet, to engage them in our services, and to help them get off the streets and move into a home. And you can see SAMHSA identifies 4 major dimensions of a life in recovery, and having a home is one of those dimensions. Living in a community and being part of a community is one of those dimensions, and so that's why this work is so important to DMH. I always like showing this slide. The treatment of homelessness is housing. It's that simple. And that's a quote by Samson Barris, which maybe some of you know him. He's in New York. And that is what we're trying to do at DMH. Although we're a mental health provider, we know that our treatment for people who are homeless is to help them get off the streets and not be homeless anymore, while we're providing all the supports necessary to do that. So our strategy at DMH to end homelessness for our clients has been pretty simple. We develop programs that have specialized community-based programs that target the homeless population. We increase our portfolio of housing resources, and we participate in the collaborative efforts going on in Los Angeles County and across the state in ending homelessness. And there is a lot of work being done. It's already been referenced by Peter and by Gabrielle in Los Angeles to end homelessness, people working together. And DMH is always at that table to be a collaborative partner. So we know that people who are homeless can walk into any of the services that we provide, and they do. But having programs that specifically target the homeless population is just critical to actually helping end homelessness. So DMH, we have our full service partnership programs, and that's kind of our flagship programs. And we have them for all age groups: children, transition age youth, adults, and older adults. And every age group targets the homeless population. But that's not the only population that they target. They also target other populations. But those programs are really important. Our integrated mobile health teams, again, specifically target the homeless population. I'm going to talk more about those programs in a few minutes. We receive funding called PATH funding. It's under SAMHSA, federal funding in Los Angeles. And under that, we have the multidisciplinary integrated teams. I'm going to focus on that today too. We have funding for our Valor program. They serve veterans, and for our home programs that do homeless outreach. We also, in the past year, started our SB 82 mobile triage teams. Service Area 2, SB 82 teams over here. Here's some noise. So, are there other SB 82 teams here? Anyone? Oh, there's one. Oh, yes. There's Service Area 5 over there. Okay. So this is, so those teams are really awesome, and they're on the streets doing homeless outreach. About 7 staff, clinical staff, and people with lived experience, community workers, working together to outreach to people in the community who are homeless, and to link them into services, and also help them get into housing. The county also has a single adult model, and this is a collaborative between DHS and DMH and Department of Public Social Services, which targets people who receive general relief from the county and who are also high utilizers of DMH and DHS. And with that program, everyone who is assisted through that program actually has a housing voucher through the program, through the Flexible Housing Subsidy Pool, which I'm sure Corinne will talk about. So we're able to help them with housing and help provide services. So programs that are focused on targeting the homeless population have several important aspects that are key to making them successful. The first of which is that they are field-based services, their street-based services, that there's many barriers for people who are homeless to actually access DMH's traditional services. Many people who are homeless, they don't come in our doors, or they don't, they've had bad experiences perhaps with DMH. They can't wait for hours, for services, or wait for weeks to get services, get an appointment. So it's very important that our teams are out in the streets, that they're the ones going to the people who are homeless and have mental illness and trying to engage them in services. So being field-based is critical. Having the capacity to provide what we call intensive services with a low case manager to client ratio is critical, because people have many needs and that need to be addressed, and whether it's as simple as helping someone get food, helping them get clothes, helping them get an ID, all of those things we have to be able to do and be flexible to do. As I already mentioned, people who are homeless often have a distrust of others, and so doing consistent outreach with the goal of engaging someone and engaging them in a relationship, a trusting relationship, that is also key to these programs. And it can take years. I've heard so many stories, probably from many of you in this room, telling me about your experiences outreaching to people and how we can't give up. It's not a short term, we're gonna try 6 times and then it's over. We keep trying and trying and trying, and it can take years. And then after those years, we don't know sometimes what it is that makes that change. But then there is a trusting relationship, and we can help someone change their lives. Which also is related to having a whatever it takes approach. That we can do whatever we need to help people. And that's why having funding in these programs that some people call flexible funding, which allows us to do things like provide food for people, provide shelter, food, clothing, transportation. Those things are really critical to these programs. Peter mentioned that many people who are homeless have experienced a lot of trauma. And so another important aspect of programs that target the homeless population is that our services are trauma informed, and that we're addressing that, and we're not re-traumatizing people, that we are trained in a way that we don't keep asking people over and over to tell their stories, which can cause them to be re-traumatized. And then of course, ultimately our goal is to focus on helping people transition into housing, permanent housing. And to do that, we have to have housing resources available for them, so we can help them access those affordable housing resources. So I'm going to focus on 2 programs today because we don't have a lot of time, although we have so many great programs to talk about. But I'm going to start by talking about our integrated global health teams, and it's just as an example of integrated care. And we developed these programs in 2011, and I'm always proud to say that we started developing them before the ACA. We said, let's have a team that it works together and has the capacity to provide physical health care, mental health care, and substance use treatment together as one team. And it was really important that these teams were not co-located. They were actually a team that was seamless to the clients, that even though oftentimes the healthcare provider was a different provider than the mental health care provider, that to the client, it was all seamless. They didn't know that there were different agencies working together, that it was just one team. We modeled these teams after the street-based medicine that was going on in Boston, and I know that actually Dr. Jim O'Connell spoke here as a keynote several years ago, and we brought him out and asked him to consult with us in developing this program. The idea is that a street medicine is not a clinic on wheels. It's people who can actually do the treatment on the streets, with whatever they need in their bag to work with people on the streets. This program had a requirement that every team have a federally qualified health center as a partner on the team. And our idea behind this, this program was initially funded through innovation funding with MHSA, and that funding encouraged counties to try something new to see if it worked. So one thing we wanted to learn and figure out is how do we braid all these different types of funding together to pay for the team. So we were hoping to braid the federally qualified health centers funding, the mental health funding, and the drug Medi-Cal funding. However, we never figured out the drug Medi-Cal funding, And I'm sure Wes is going to talk about that. I think there's going to be some opportunities in the future with the drug medical waiver to actually figure that part out. And then also the FQHCs, I have to say from a mental health perspective, it was very hard to learn how their funding works, what they can actually pay for. So that was all learning for us. So these teams provide street-based outreach, having people on a team that can address the mental health, substance use, and physical health issues of the people we're working with allows us to have a no wrong door approach, because we might be able to engage someone because of their sore on their foot when they don't want to talk about their mental illness. And that's the beauty of having a team with so many different specializations, is that we can engage them in whatever door the person wants to deal with at that point. Also, this team incorporated the evidence-based practices of Housing First, permanent supportive housing, harm reduction, and motivational interviewing. And so, again, those are the best practices across the country in working with this population. The IMHT teams, they each served 100 individuals that were homeless, had severe mental illness, and it was a requirement for this program that they also had a co-occurring physical health condition and or a substance use disorder. Honestly though, almost everybody that got in the program had a tri-morbid condition of all three. So we really wanted to make sure that we were serving the most vulnerable people on the streets. We used the Vulnerability Index Service Prioritization Assessment Tool, the VI-SPIT, you probably have heard of it, which is the Los Angeles County, the assessment tool we're using to assess vulnerability for people who are homeless. The staffing, as I mentioned, include the federally qualified health center partner. We leveraged the FQHC funding, but also, we didn't want the FQHCs to not want to participate because they were afraid to lose money because they might have to do things that they couldn't actually claim for. So we did allow MHSA funding to be used as gap funding for the staff time of the FQHC staff for services that could not be claimed to another source. The IMHT staffing, this was a very richly funded staffing pattern that included a physical health practitioner, which is the FQHC, psychiatrist, the social worker, substance abuse counselor, case managers, and peers, which we also think are really key to homeless programs, are having people with lived experience, especially lived experience of homelessness and mental illness on the teams. So this is one of our IMHTs, the Exodus Recovery, and their FQHC partner is LA Christian, and they're doing outreach here. The women in blue, wait, where are they? They're all here, I saw them. There they are, back there in the corner. Thank you. I didn't know they were going to be here when I put this together, and then I saw them all when I got here this morning. Oh, I have pictures of you. So the woman in blue here is the physician's assistant who's part of the team, along with the other case managers in this picture. This is their psychiatric nurse practitioner outreaching to someone on the streets. And then this, again, is the team working together, and the team here includes the psychiatric nurse practitioner, the medical assistant, and case manager. So these are just examples showing how it's, the team working together on the streets, and that is really how we designed this team. With IMHT and all of our innovation programs, UC San Diego did an extensive analysis. We did a lot of data collection for this program, and they did an analysis for us. And when the program, it was a 3-year pilot, which ended in June 2015, and then converted to a full-service partnership program. So in 2015, in June, when the program ended and we got our final analysis from UC San Diego, 75% of the clients showed significant improvements in overall health, and we had many different health measures that we used for this. 73% of the clients made significant progress in their recovery, 33% of clients had a significant reduction in alcohol consumption, and 28% of clients had a significant reduction in drug use. Also, there was a significant decrease in emergency services. Reductions in inpatient and emergency department resulted in $303,000 of costs avoided. And as Gabrielle said, there's been lots of studies across the country to show that if we can help people who are homeless move into housing, it actually costs the public system less money because they're not as likely to use emergency services and all of the fire department, police department, and getting arrested and all those things. And then also 60% were enrolled in permanent housing. And actually the Exodus LA Christian team their services are located in a housing development because it was a requirement that they partner with housing